Hi, this is Philip Ador, founder of NCLEX RN 45-Day Challenge. In this video, I'm going to be talking about sexually transmitted disease. HIV, or human immunodeficiency virus, is a virus that targets cells in the immune system. Over time, the immune system begins to fail, which is called the immunodeficiency. And this increases the risk of infections and tumors that the healthy immune system would usually be able to fend off. These complications are referred to as AIDS, or acquired immunodeficiency syndrome. Now, there are two distinct types of HIV. HIV-1 and HIV-2. HIV-1 is more commonly associated with AIDS in the US and in worldwide. HIV-2 is more rarely typically restricted to areas in Western Africa and Southern Asia. HIV-2 is uncommon that HIV almost always refers to as HIV-1. Alright? HIV targets CD4 cells, meaning cells that have this specific molecule called CD4 on their membrane. Macrophages, T helper cells, and the dendritic cells are involved in the immune response in all of the CD4 molecules. Therefore, they can be targeted by the HIV. The CD4 molecule helps these cells attach and communicate with other immune cells, which is particularly important when cells are launching attacks against foreign pathogens. So these little molecules is pretty important for our immune system. But it's also extremely important for HIV. HIV targets and attaches to the CD4 molecules via a protein called the GP120, found on its envelope. HIV then again uses GP120 to attach to another receptors called co-receptor. HIV needs to find both the CD4 molecules and the co-receptor to get inside the cell. The most common co-receptors that HIV uses are the HR4 co-receptors, which is found mainly on the T cells. On the CCR5 co-receptors, which is found on the T cells, macrophages, monocytes, and dendritic cells. These co-receptors are so important for HIV that some people with homogeneous genetic mutations in their CCR5 actually have resistance or immunity to HIV. Since HIV can attach to them and get into the cell, in fact, even in heterozygous mutations, which lead to a fewer co-receptors on the cells, can make it harder for the virus to spread and results in a slower disease progression. For those without these mutations, though once HIV binds to the CD4 and either to a CCR5 or CXCR4, it gains access into the cell. HIV is a single-stranded positive sense envelope RNA retrovirus, meaning that it injects its single-stranded RNA into the T helper cells. The retro part of the retrovirus isn't referring to its style, but refers to it needing to use an enzyme called reverse transcriptase to transcribe a complementary double-stranded piece of proviral DNA. Proviral just means that it's ready to be integrated into the host DNA. So it enters the T helper cell's nucleus and pops itself into the cells of the DNAs. When the immune cells become activated, they start transcribing and translating proteins needed for the immune response. Ironically, this means that whenever the immune cell is exposed to something that causes it to start an immune response, like any infection, the immune cells ends up inadvertently transcribing and translating new HIV virus, which butt off from the cell membranes to infect more cells. One thing to know is that HIV is notorious for making errors when it replicates, and that during the infections, it can mutate to create slightly different strains of the viruses. These viruses are all still considered HIV, but they behave slightly different from each other and target different cells in the host. In fact, the host cell preference is called viral tropism. So let's start with HIV, entering the body through the sexual intercourse, which is how it typically spreads from the person to person. At this early point, during what we call acute infections, the R5 strain of the HIV, which binds the CCR5 co-receptors, will get into the macrophages, dendritic cells, and the T cells. Usually, dendritic cells hang out in the epithelials or mucosal tissues with viruses enters the body, captures the virus, and migrates into the lymph nodes, where a lot of immune cells live, and the R5 strain of HIV essentially has a field of day, infecting T helper cells, macrophages, and more dendritic cells, which leads to a big spike in HIV replications and the amount of viruses found in the patient's blood, and starts to control the amount of virus replications, and the amount of virus in the blood declines to lower but still detectable levels by 12 weeks, at which point the patient enters into the chronic or clinically latent phase, which can last between 2 and 10 years. If we plot the amount of T cells alongside the amount of virus, we see that they loosely mirror each other. Initially, you have considerable decline in the acute phase until the immune system mounts its counterattack. At this point, even though there might not be any clinical signs or symptoms of the virus, is steady chipping away at the immune system. And the number of the viruses in the blood slowly increases, while at the same time, the T cells slowly decreases, losing about 1 to 2 billion T cells every day. During this chronic phase, T cells counts usually remains above 500 cells per cubic millimeter, which is about the size of the head of a pin. The patient can still fight off the infections fairly well, although some of the infections, like tuberculosis, become more common and severe. Now, remember how HIV can create mutations. Well, during the chronic phase of the HIV infections, it's worth pointing out that some of the patients develop X4 strain of the HIV which targets the XCR4 receptors, which is essentially only the T cells. These X4 strains kind of lay low in the lymphoid tissues and steadily destroy the CD4 T cells, since about 90% of T cells are around in the lymphoid tissues. Not all patients develop the export strain, though it's not completely clear what the presence of the strain implies about the disease of the course. When the body cells drop low enough between about 200 and 500 cells per cubic millimeter, patients start experiencing symptoms like swollen lymph nodes for lymphadenopathy, as well as relative minor infections like oral or hairy leukoplakia, a hairy-looking white patch in the side of the tongue caused by the same Epstein-Barr virus that causes the mononucleosis, as well as the oral candidiasis, a yeast infection in the mouth. As more T cells are lost and the levels falls below 200 cells per cubic millimeter, the immune system becomes severely compromised, and at this stage, the condition has progressed from HIV disease to AIDS. At this point, people experience things like persistent fever, fatigue, weight loss, and diarrhea. And the HIV count in the blood might increase significantly. At this point, certain conditions start to develop that are said to be AIDS-defining, such as recurrent bacterial pneumonia, pneumocystic pneumonia, and fungal infections like candidiasis of the esophagus. Other conditions include certain tumors in malignancies like Kaposi sarcoma, which causes lesions in the skin and other soft tissues, and primary lymphoma of the brain. Many people with AIDS die from the infections that a healthy immune system would typically be able to fend off, like pneumocystic cytomegalovirus or Mycobacterium avium complex. Now, male-to-male transmission is the most common mode of transmissions in the US, and male-to-female is the most common mode in resource-limited setting. Although less common to female-to-male transmissions occur as well, as since HIV is present in the vaginal and cervical fluids of the infected woman. In fact, over 75% of all cases of HIV are contracted from sexual intercourse. The next most common means of transmissions include things like intravenous or drug abuse and mother-to-child transmissions, which can be via the placenta during the delivery or via the breast milk. Other much less common modes of transmissions include accidental needle sticks and use of blood products like blood transfusions. As far as the diagnosis goes, there are a few types of HIV tests can be done: antibody test, antibodies antigen test, and an RNA DNA test. Antibody test for antibodies that the body's made against the HIV. Antigen test looks for the virus directly, so antibody antigen test detect both antibodies to the virus as well as the virus itself. RNA tests screen for viral RNA, so they also detect the virus directly. And the DNA tests look for the copies of the viral RNA. Since remember, it's the retrovirus, so it copies its genetics materials into the DNA. For screening purposes, the recommended test is the antibody antigen test, which is better at identifying early infection. It's also recommended if the first test is positive to follow it with a confirmatory test that looks for the antibody or the nucleic acid. There's currently no cure for AIDS. Treatments, however, can help somebody with AIDS live longer, healthier lives, and help reduce the risk of transmission. The primary method is to use the antiretroviral therapy or the ART. ART isn't a single medicine, but it's a combination of medicines that's known as an HIV regimen. This helps slow down the HIV replications, which gives the immune system a chance to recover and help fight off the infections more